vivo agora. Agradeço o professor Ayrton Stein, nosso professor titular do Departamento de Saúde Coletiva, pela participação, mas eu gostaria muito de apresentar o nosso ilustre convidado, o Dr. Robert Janett. Ele é consultor do Banco Mundial, consultor global para o Banco Mundial. Ele tem 40 anos de atenção primária e é professor da Harvard University. Então, e hoje ele vai nos falar sobre um assunto que para nós vai ser muito importante, já está sendo agora, mas eu entendo que para os próximos meses e talvez anos a gente vai ter que estar lidando com as consequências disso, que é o burnout nesse tempo de pandemia. Robert?
Obrigado, gente. Obrigado pelo convite. Se posso compartilhar minha tela?
Pode. E eu e o Ayrton vamos desligar as câmeras. Você compartilha ali embaixo em apresentar agora. Embaixo.
Já pode vir minha tela?
Já está aí. Já está,
Muito
sim.
Bom. Então, galera, boa tarde. Me chamo Rob Janett. Sou médico da atenção primária aqui em Cambridge, Massachusetts, e faço muitas visitas à Universidade Federal de Ciências de Saúde de Porto Alegre, e amo muito sua universidade. E obrigado pela oportunidade de compartilhar nossas pesquisas e informação sobre esse tema do burnout na época da Covid-19. É muito importante porque essa pandemia é muito pesada para nós, para prestadores, também pelos pacientes. E eu quero falar sobre burnout, mas também sobre as soluções para burnout, o que podemos fazer para fazer intervenções nessa síndrome. Vou começar a falar em português, mas vou mudar rapidamente ao inglês, porque não tenho o vocabulário completo para dar essa palestra em português. E tenho que referir a um quadro, um PowerPoint, que eu mostrei o ano passado durante uma visita à sua universidade, para dar uma palestra sobre empatia no saúde. E falamos sobre compaixão e empatia, que é o papel do médico. Esse é nosso papel fundamental em nossa querida profissão de medicina. Mas, às vezes, é difícil para manter nossa compaixão, nossa empatia, e temos que confessar que, às vezes, temos que desculpar nossas próprias pessoas, aceitar nossas imperfeições. E essa é no assunto dos profissionais, também no assunto de pessoa humana. E a tela final dessa última apresentação sobre empatia foi dessa pensadora judaica, e essa dica famosa, para não esquecer que, primeiro, fundamentalmente, temos que atender nossas próprias, porque sem autoatendimento, como podemos atender os outros? Isso é essencial, porque agora temos uma situação extremamente difícil. E a situação é Covid-19. E agora vou mudar a inglês, desculpa, mas não tenho vocabulário. All of us now are witnesses to enormous suffering among our patients, and honestly, enormous suffering among our colleagues, and an unimaginable number of deaths. And deaths not just in people who are already at the end of their lives and and in the final stages of a chronic disease, but deaths from an acute disease, from an infectious disease that's taking people young and old from us very quickly and unexpectedly. And we have to also recognize that along with this suffering and death that we're witness to, we are also witnessing a period of enormous social disruption, with social isolation because of the quarantine, and increasing poverty because of the economic damage from the pandemic and the quarantine. And this magnifies, in many respects, the disparities that have already existed in our societies. They've already been present, but are now so much worse. And those disparities are reflected both in the economic consequences of this pandemic, but also in the health consequences of this pandemic. It is not striking evenly across our societies. It's disproportionately impacting poor people, Black people, Indigenous people. In my country, the immigrant communities are severely impacted. And as we as doctors, nurses, medical students, respiratory technicians, and others struggle with this enormous wave of disease and death, we're getting tired. We're really getting tired. And, normally, under normal circumstances, we face a crisis and we have a quick reaction to that crisis. And then what should happen is after that quick reaction, we experience a slow recovery. So we become frightened, we act, and then after that, there's calm. So there's a surge reaction and then time for a reset. So I would say that at the beginning of this crisis, back in March, back in April, we all were in surge mode. But did we reset? Did we recover? Many of us really did not. And, the other point that is often not discussed is, along with this fatigue and pressure, as professionals, we're called upon in many ways to remain calm and cheerful and optimistic. And by the way, not just health professionals. The same is true for teachers and clergy and parents. So, really, we should have no shame in our exhaustion or in our grief. And yet, we do. We do. And that's an important fact to notice, that there is somehow a failure to acknowledge and accept our own frailty. This is from the New York Times. And this was the story of Lorna Feist. She was an emergency room physician in New York. And she worked tirelessly day and night on the front lines and was completely overwhelmed with the volume of death and advanced disease that she confronted in the emergency room, with inadequate resources to attend to all the patients who were flooding into her hospital. And she became depressed. She became despondent. And I have to tell you this, we know what she was thinking because her sister wrote an article about her in a journal. And her sister, who's an attorney, not a doctor, said that she was afraid to get help. She was worried that if she got help, it would negatively impact her career. And I'm sad to say that this physician went on to take her own life. Now, suicide among physicians in the United States is actually not uncommon. There are over 400 of them in every given year. And, you know, all of us have been touched at one point or another at this type of tragedy. But, you know, Lorna's experience is illustrative of someone who went beyond the breaking point. Now, you know, not only are we frightened and overwhelmed and exhausted from all of the work and the suffering that we're witness to, but we're also worried for our own safety and for our own health and the health of our loved ones. Because, you know, there's evidence that healthcare workers have up to a 10-fold increased risk of contracting COVID compared to the general population because of the characteristics of our work and our contagion, and also because in some cases we have not been given adequate protective equipment and supplies to keep ourselves safe, particularly during the last surge when we ran out of masks and gowns and were reusing paper supplies in order to have enough to take care of patients. And just like the general population, these risks of contracting COVID at work are not evenly distributed among all healthcare professionals. Nurses, for example, have a much higher risk of getting sick with COVID than physicians. And the disparities of poverty, of race, of ethnicity are also reflected in some of the disparities in complexion of healthcare workers ourselves. And so just as it's a problem in the larger society, it's a problem within our own healthcare institutions. The main point is we have this double burden of exhaustion and fear, which is heavy, a heavy burden to bear, and it can lead to burnout. And then in my country, we had an additional blow right before the election because a man who was candidate for the presidency, who currently occupies the office of presidency in the United States, during one of his campaign rallies, made the erroneous statement that doctors benefited from COVID because we would get $2,000 more for every case of COVID we diagnosed, and therefore, he alleged, doctors are overdiagnosing COVID and inflating the numbers to inflict political damage on him. Now, if we weren't already exhausted and depressed and frightened, then false allegations like this, which undermines the public's confidence in the profession of medicine, only made it worse. And of course, organized medicine in the United States immediately struck back at this presidential candidate. But nevertheless, the damage was done in public discourse, and it was hurtful and difficult to bear. So the topic of COVID is important because it illustrates in an extreme way the kind of pressures that healthcare providers work under all the time. But way before COVID, there was a very important report put out by the National Academy of Medicine with very, very esteemed authors that identified burnout of clinicians as an important problem and reviewed the literature to propose solutions to burnout that had been established from experience and from the literature. So the publication date of this is recent. It's 2019. It's available for free on the internet at the National Academy of Science of the United States. It's a long, long monograph, but I want to share with you some of the salient features of this monograph, along with features of the rest of the literature on burnout that are appropriate to this discussion. So first of all, we want to define the syndrome. And the syndrome of burnout has three cardinal components. First, there's emotional exhaustion, something that we can all relate to directly. Secondly, there's this concept of depersonalization, and it might otherwise be termed cynicism, where suddenly you step outside of your professional mindset and feel that you're constantly under attack and that your work is not worthwhile, and that the patients perhaps don't deserve your energy and work. It's a terrible moment when this sets in. But, you know, the point is that when you're exhausted and when you feel depersonalized, you build a wall around yourself, and you're no longer the caring physician that you were trained to be. And then the third characteristic is this loss of sense of professional efficacy, that no matter what you do, you can't be effective in your work. And it makes you feel incompetent, even though you may well be as competent as anyone. It makes you feel incompetent. It feels that you cannot achieve your goals. And your self-evaluation is in the negative. Now, this is a very prevalent syndrome. Research has shown that between a third and half of US physicians and nurses display these three symptoms of burnout at some point in their career. And it's even more prevalent among the trainees, the students and the residents. So in the monograph from the National Academy, they developed sort of a graphic, you know, an overview of this issue. And it's a helpful way to conceptualize burnout. So I'm going to hopefully use my pointer here. Hopefully you can see it. You know, first of all, there are the domains of practice. So there are problems in frontline care delivery, the dark green inner circle. Then there can be factors in the healthcare organization in which that care delivery is posited, and that too can contribute to burnout. And then finally, there are factors in the external environment that can influence all three of the other circles. And I just gave you a big example that when Mr. Trump says that we all make $2,000 more every time we diagnose COVID, it's an external factor way beyond us that demoralizes us. So these are the work system factors that generate burnout. Now, remember that we're all individuals, and we have our own individual factors that may or may not make us more or less susceptible to burnout. But in any event, when you have the right environment and individual factors, the outcomes can be either well-being or burnout. And whether we have well-being or burnout will influence there will be consequences. It will influence our work. It'll influence the patients themselves. It'll influence ourselves. It'll influence our organization and society at large. And if we learn from this, we can bring back improvement and improve all of these domains. So this is the overall schema that I am working with as I think about burnout. Now, this is a key step because there is a diagnosis for burnout. In the ICD-11, there is a burnout diagnosis that follows these three characteristics, and it excludes other mental disorders. But the key factor in both the ICD-11 diagnosis and in the World Health Organization's definition of the burnout diagnosis is that it results from chronic workplace stress. So chronic stress and workplace are the three key words. But it's only applicable in a context of workplace stress for the purposes of healthcare. Obviously, there's burnout in other fields, and we can talk about that, but that's not our topic of today. So countering burnout, countering this triad of exhaustion, depersonalization, and lack of self-efficacy is another factor, and this is well-being and resilience. So, you know, well-being and resilience is something actually that's very prevalent among physicians. As a profession, as a population, as a group of people, studies have shown that we as healthcare providers tend to be more resilient than the average person. And so, you know, what is well-being? And again, let's look at definitions. Well-being is satisfaction, finding meaning in our work, feeling engagement, and feeling fulfillment. And you can think to yourself, where are the places that bring you the satisfaction, the meaning, the fulfillment, the engagement? Because when we're talking about well-being in health, we're talking about fulfilling your social mission. And the mission that brought you to the profession originally, to help people, to form effective relationships with people, to heal them, and to engage with your patients. Now, resilience, a similar related topic, really involves the ability of a person to adapt, to recover, to rebound, you know, or even grow from some kind of stress or adversity or trauma. And as I said at the top of the talk, during COVID-19, we're exhausted, we're stressed, and our normal reaction is to be resilient and to rebound if we're given the tools and the space and the time to do that, because it's in our nature to do that. So I'd like to just contrast for a minute stress and burnout, because we often mix these two terms up. They're actually quite different, because stress in health professions is always present. It's universal. It's there from day one, and it'll be there throughout our careers, because we work in a high stakes, high value environment where our work is extremely important and lives are on the line. So when we have stress, we actually are over-engaged in our work. You know, we can't escape it. We're over-engaged. And our emotions during stress tend to have that adrenaline-driven, overactive characteristic. And we feel that our work is urgent and hyperactive. Just think of how you feel when a cardiac arrest code is called and you rush to the bedside, and there's all of this frenetic activity and urgency and overactive emotions. Now, with stress, you often have at first a high energy state followed by a loss of energy as you run out of energy. And stress can lead to anxiety. Now, chronic stress can lead to physical and emotional damage, and you want to manage stress, certainly in your life and in your career. But that's not burnout. The symptoms of burnout, the signs of burnout, the consequences of burnout are in certain ways the opposite of stress. They come from chronic stress, but they're the opposite of stress. In burnout, you get to the point where you're no longer overengaged. You're underengaged. You're unable to mount the effort to be engaged with the patient's problems, emotions, and needs. And your emotions themselves, your emotions, become blunted as opposed to the overactive emotions you experience during the stress. And whereas you might have felt urgent and hyperactive during stress, in burnout, the emotions are helplessness and hopelessness. And unlike under stress where you lose energy, in burnout, you lose motivation and you lose your link to your ideals, your values. The consequences of stress can be anxiety, but in burnout, it's more commonly detachment and depression. And in this case, there's also physical and emotional damage, but in stress, the physical damage tends to be more pronounced than the emotional damage. In burnout, it's the opposite. The emotional damage is more pronounced than the physical damage. So there are consequences to burnout. You know, the real point here is that there's actually a bi-directional relationship between physician well-being and patient care and safety. So that when we're not well, when we're not feeling well, when we're unable to mount the effort, patient care and safety suffer. And so, you know, we can have all kinds of personal consequences. There's evidence of worsening cardiovascular disease, increased risks of occupational injuries because of inattention, depression, and like the case I presented early on, even suicide. But there's really a dose-response relationship between burnout and this hopelessness that leads to suicidal ideation. And that dose-response relationship has actually been identified in numerous studies. I referred to 3 of them from the literature from 2008 to 2011. But what we've also seen is that over time, as burnout improves, these thoughts of suicide also improve. And so there's really causality here. And I hate to go to the most extreme example, suicide. It's a very painful topic for all of us, but it's important. The other point is that there's a very, very significant and direct impact of burnout on our job performance. People leave work. They stay home from work when they have burnout. They are absent. And, you know, the absences tend to be long-standing, so that there's evidence that work absences from burnout can persist for 1 to 2 years after the onset of burnout. People take sick days, people don't show up for work, people are late. But worse than that, sometimes people actually come to work, but then don't work effectively and don't do a good job at their tasks. And in healthcare, you know, that's a very serious problem because it impacts the quality of care. There was a meta-analysis of 27 studies involving over 42,000 physicians, and it showed that burnout was associated with an increased risk of patient safety incidents, poor quality of care due to low professionalism, and reduced patient satisfaction. But the productivity loss from burnout in the United States alone is equivalent to eliminating the graduating classes of 7 medical schools. You know, we invest, you know, $500,000 to $2 million per student to train a fully qualified doctor. And we are losing the equivalent of a 6 or more of those classes, those schools, in every given year because of burnout. So going back to that diagram that I showed you earlier with the circles, you know, what are some of the work system factors that evidence has shown contributes to burnout? Well, there's a number of them. If our jobs demand that we do things beyond our capacity or beyond our skills, we're likely to burn out. And in my hospital during COVID, we had people who were really not qualified to be intensive care unit physicians placed in the intensive care unit because they needed more hands, and they were under supervision, but it was a frightening time to be a family doctor accustomed to office practice, suddenly thrust into an intensive care environment. Administrative burdens, excessive paperwork, documentation demands, audits and things, administrative tasks that interfere with our ability to perform our professional duties clearly lead to burnout. Work environments where we feel that we have no autonomy, where we're over-supervised, where we don't actually have involvement in the making of fundamental decisions that rule our workplace, that leads to burnout. Another factor that's important is when we're distracted. You're trying your best to complete the task at hand, and yet your cell phone or your pager keeps going off, or the alarm in the intensive care unit keeps pulling you away from the patient you're trying to evaluate or treat in order to deal with something else. And this level of distraction is a significant factor in producing burnout for clinicians. Technology can be helpful, but it also can be a burnout factor if it's designed poorly. And I want to talk about that in a minute. When our work demands such excessive time from us that it encroaches on our personal life, and I think every one of us can relate to this factor at some point in our training or our work. I was working 110-hour weeks when I was a house officer, a resident. It encroached on my family life. I mean, I am lucky that I'm still married 40 years later because I wasn't home. And that took a toll on me and on my family. Moral distress is an enormous topic. I want to talk about it in a minute. I'm not going to mention it more here. And then, of course, there are patient factors. I mean, there are some patients who are honestly quite difficult to deal with. And when you have patient after patient who is either inappropriately demanding or in other ways challenging to manage emotionally, behaviorally, that can contribute to burnout too, unless you have the appropriate tools and supports to manage them. Coming back to technology for a minute, technology can either make it or break it for us in terms of burnout. I use an electronic medical record. I frequently say that if I ever had to go back to paper, I'd just quit because I couldn't do the job I do without a well-designed, well-appointed electronic medical record. But if it's poorly designed, if the interface is not effective, if the record demands tremendous amounts of time and attention just to achieve documentation, it can contribute to burnout. I remember when we implemented our electronic record, and we went through so much Kleenex, so much tissue to deal with all of the tears of all of us as we tried to learn this new system. Fortunately, that is now passed and it's working quite smoothly. So it's a double-edged sword. It can go either way. And then lastly, this gets to managing information. The amount of medical information available to us is exploding. Ayrton Stein can tell you how many randomized controlled trials are published every year. It's measurable in the tens of thousands and maybe the hundreds of thousands. I don't have the number at my fingertips, but the fact is it's virtually impossible to keep up with all of the information that is available to us. And it really takes good technology to sort that. And if we don't have good technology, it's overwhelming to us. I want to turn briefly to a subject that is very difficult. It's a philosophical subject, and it's about something we call moral injury. There's actually a project, a center at an American university, at Syracuse University in New York State, where they study moral injury and write about it. It's a very interesting topic. It was originally derived with reference to military veterans, people who went to war and were impacted socially, spiritually, emotionally by acts of violence, by violence that they had to witness, by violence that they may have had to participate in. And a soldier has little choice but to fight when in a war zone, and sometimes asked to do things that he or she finds to be against their moral code of conduct. But they do so under orders. There's lots of examples of this from every war, every just war and every unjust war. But it's the source of a lot of post-traumatic stress disorder illness that we see in military veterans. And so this whole field is well articulated around military experience. But, you know, in many ways in healthcare, the same applies to us. You know, when we're in a situation, as we all have been in the recent surge of COVID, and which I dread we'll all be in again when the next surge hits, you know, this sense that you can't act according to your professional values because of either duress or limits or constraints. You know, we don't have the drugs we need to keep people comfortable. We don't have the equipment we need to protect ourselves or to properly treat patients. There's a shortage of ventilators, and we have to decide who lives and who dies because not everyone can have a ventilator. There's a shortage of intensive care unit beds. There's plenty of examples from Brazil, from parts of the United States, and from all over the world where patients were left to die at home or in the streets because they didn't have access to care. But, you know, these morally undesirable circumstances that we're literally thrust into in COVID-19 that generate burnout and generate trauma to us don't just happen during a pandemic. It happens all the time, actually. I mean, how often have any of you been asked to participate in care that is either futile or potentially harmful to the patient because someone, whether the family or a specialist or someone on the care team, insisted that we had to do X, Y, or Z, even though it was against your better judgment? And if you are a nurse, if you're a medical student, if you're a resident, the chain of authority is such that you can't overrule the decision to proceed in that futile or harmful treatment. And that's hurtful, and it produces moral distress and moral injury. We see this all the time with unnecessary interventions that we witness day in and day out. You know, the overtreatment problem in Brazil and the United States, the overprescription, the overuse of imaging studies, the overuse of elective surgery. If you're thinking about it, if you're cognizant of it and realizing that all of this overtreatment does not benefit patients, it can cause moral injury to you. We can have moral injury when we're part of a team that's giving a patient or a family false hope. You know, if we only do this, perhaps the stage 4 cancer will regress a little bit. But you know and I know that the patient is terminally ill. But we can't steer the team to give the truthful prognostic information to the family or the patient. And lastly, you know, when we're forced to work in an environment where the staffing is unsafe, where we just don't have enough nurses, and a nurse has to care for 30 patients by himself, or a resident has to do 20 admissions in a night because there's nobody else to do those admissions. Now, normally, this would be unacceptable to us, and we wouldn't do it. But because we're in a hierarchical organization, there's a workplace-mediated injury to our moral code, and this generates burnout. So, you know, to start to move toward thinking optimistically about burnout, now that I've laid out what is really a very pessimistic picture, I want to think about the profession of medicine and what it means to be a professional, and these characteristics that we have in our profession that come from the American College of Physicians Ethics Manual, recently updated in 2019. You know, ideas of integrity and altruism, fairness, compassion, respect for the dignity of all persons. These are ideas that we all value. There is not one of us that doesn't fully embrace each of these 5 characteristics. But, you know, at times of COVID and at other times, you know, there are threats to our professionalism. You know, we want to do this. We want to act with integrity and altruism and fairness, compassion and respect. And yet, you know, here's a photograph from a hallway of a hospital in Brazil, and it's very difficult to maintain professionalism when there's a conflict between your values and what you can actually accomplish. And it's not just the understaffing, overcrowding crisis of COVID. The same conflict can occur in complex regulations when we have cost reduction pressures or pressures to increase revenue to see more patients in less time, even though you feel like you can't. These are threats to professionalism. And then, you know, the last thing to think about in terms of professionalism is mythology. You know, there's an erroneous idea in the culture of medicine. And I like to talk about this and think about this. It's a very erroneous idea and a dangerous, ineffective idea, which is that physical and emotional exhaustion are part of our job, and we have to learn how to function despite physical and emotional exhaustion. That vulnerability on the part of a health professional is a sign of weakness. I mean, this is one of the factors that led to that emergency room doctor's suicide, that she was afraid to show her vulnerability. You know, there's a myth of the hero. Being a hero is not a good thing. It's not a good thing because there's this high level of expectation. We're not heroes. We're good people working in a profession with good training and good equipment and good values, but we're not heroes because a hero is infallible. You know, this is a pernicious overemphasis on the ideas that we're personally resilient, that we can manage distress as individuals, you know, and it generates stigma and it generates isolation because we know that we can't. And then lastly, in this whole chain of burnout, there are the individual factors that I referred to. You know, we have different personalities, we have different temperaments. Some can absorb more than others. You know, some of us have better coping strategies than others. Some of us are more resilient than others. Some of us have more supportive personal relationships and better social supports than others. But these factors, our temperament, our coping strategies, our resilience, our relationships, this is what we use to manage stress and manage burnout. They're not evenly distributed among the population of healthcare providers. But see, the error, and this is the error that I want to underline and emphasize, that if you remember nothing else from today, you remember this. Individual factors alone don't overcome burnout, because burnout is an occupational related hazard. So no matter how resilient you are, no matter how supportive your family is, no matter how even-tempered you are, you're still subject to burnout if you're thrust into situations that chronically cause you moral injury. So this same monograph that I've referred to thinks about factors that can improve well-being and improve resilience, and they revolve around a number of domains, from personal factors and certain skills you can learn, like how to be a better meditator, etc. And then things that are in your work environment, in society and culture, the regulations we work under, the practice environment and our responsibilities. But they all surround the well-being of clinicians. And if you have clinician well-being, then you have better clinician-patient relationships, and accordingly, you have better patient well-being. So it all matters. So what can reduce burnout? Well, I already mentioned that strong relationships can help build resistance and resilience among physicians, family relationships, social relationships, but there's other relationships. I asked you earlier to think about the kinds of factors that lead you to find meaning in your work, find satisfaction. And where do we get that? Usually from relationships with patients. The place to reach to when we're feeling burnout is to deepen our relationships with our patients. And then accordingly, similarly with colleagues, with teachers, with mentors, because these relationships are the antidote to burnout. Secondly, the leaders of the organization really have to commit to well-being of residents, of students, of all workers, of physicians, because without an organizational commitment, the burnout won't improve. There are a host of specific interventions I'll list. And then finally, and this is where time out matters, we need time for reflection. When we are exhausted, when we have chronic stress, we can lose sight of those rewarding, inspiring moments in our work. And so we need time to be able to think about them. So again, if you look at the diagram and think about the domains here, we want to create a positive work environment, a positive learning environment. We want to reduce the administrative burden on us. We want to enable technology to be helpful, not harmful. And we want to support clinicians and learners alike. So there's things that organizations like the university, like your hospital, like your clinic can do. You can work in teams so you can support each other. You can think about how usable your technology is and ask the technology people to improve them. You can engineer alerts and warnings to avoid the excessive interruptions, what we call flag fatigue. You're going to reduce burnout when you collaborate more, when you enhance professionalism, and when your communication is better, because these are the antidote to isolation. Incentives can help. It's not all about money, because in fact, there's really strong evidence that burnout exists across the income spectrum. Just paying people more does not reduce burnout, but there can be incentives that can be effective. And then lastly, there needs to be an environment of safety. It needs to be safe to seek help so that burnout factors can be reported and addressed by the organization. And there cannot be stigma or shame or retaliation or disrespect when someone reports distress. Next, we can focus on programs, because programs can help. Exercise is clearly an antidote to burnout, and I hope you can maintain your exercise through this pandemic. Mindfulness training, something we talked about in my last lecture a year ago, is helpful. We have balance groups where we talk about patient interaction. We have an organization called Schwartz Center Rounds. They're grand rounds that focus on the human qualities of medicine. You can practice emotional first aid, and there can be formal programs of support Emotional or psychological first aid is a well-known field. There's a guide in Portuguese, by the way, by the World Health Organization that you can access for free, but includes promoting safety, maintaining calm, creating self-efficacy, creating social connections, and creating hope. And you can do this fairly efficiently, even in a crisis, to help reduce the emotional trauma on your coworkers and on people who you supervise. It's worth looking at this material. At Cambridge Health Alliance, throughout the pandemic, we had daily employee wellness activities, most of them virtual, but there was yoga, there was mindfulness. We had, private drop-in sessions that could be done generally on Google Meet, but confidentially, and handy guides on managing your own emotions. Moving to you as a person, what can and should you do? You should recognize that stress and burnout are real and they're threats. So there's things that you really need to do to take care of yourself. You have to exercise and you have to eat healthy food. You need to assure adequate sleep, because when you're not sleeping well, you're much more vulnerable to burnout. Avoiding substances such as excessive alcohol, tobacco, and other things is not only a symptom of burnout, but it makes your ability to adapt less acute. When you need it, you need to take time out. And we have to work that out so that everybody can get a break. Take your vacations. Turn responsibilities over to other people. Trust them and leave the workplace so that you're not ruminating about the problems there 24/7. Look for friends, look for colleagues to talk to. And then lastly, forgive yourself. Remember that you're human, you're imperfect, you can't do it all. And engage in acts of conscious self-compassion and self-forgiveness. This talk would not be complete without a word about specific issues for residents and students, because burnout really can impact our academic performance, our empathy, our altruism, and our personal health. I already talked to you about the loss of productivity, but one of my favorite books is Atul Gawande's book on the Checklist Manifesto. Checklists are very useful tools, but in training, there's a report in that book from a student, her name was Sonali Banerjee, who said that, with each year of training, she became more and more about checking the boxes and getting things done and less about the patient. This is a real risk of training, that you're so focused on the tasks, you forget about the patient. We can help you. We can improve the learning environment by giving you more support from peers and mentors. Competitiveness is pernicious and should be decreased. We should really focus on collaboration. And then, skills to just take better care of yourself, and certainly identify people who are isolating and reduce social isolation. Evidence is clear. COVID-19 is making all of this worse for trainees, just as it is for your faculty and your mentors. It's difficult. I'm closing now, and I want you to think about human connections, because human connections heal. They heal patients, but equally important, they heal us. We chose medicine for a reason. It's a profession that we chose to help other people. And these connections between us and the patients really are the foundations of this healing relationship. We heal them, they heal us. So what can you do? Turn to other people. When you're feeling stressed and burned out and starting to feel cynical, try to reframe the experience to find meaning and find satisfaction. Take care of yourself with balance. Take time off. Eat well. Exercise. Get enough sleep. Engage in the arts. Turn off your technology. Set boundaries. But as I said twice already, forgive yourself. Don't expect perfection. Remember, you're human. So get help if you need it. You know, there's a really famous saying by Martin Luther King that I just want to close with. This has been a very dark time for us during this COVID surge. But Martin Luther King said that only in the darkness can you see the stars. And although it's very dark for us right now, and we're really at high risk of exhaustion and burnout, when you see the selfless devotion that people give and maintaining these human connections, despite masks and facial shields and suits of personal protective suits, we still maintain these connections with our patients and with one another. We can't hug, but we can be there for one another, and we can be there for our patients. And in the end, that's what will get us through. Thank you very much.
Robert, muito obrigada pelas tuas palavras. Eu acho que trouxeram para a gente uma série de pensamentos, pelo menos eu estou aqui borbulhando de
eu também.
Em relação a isso. Eu acho que tem vários elogios para a tua fala, tá? Então, aquilo que a gente estava conversando antes, tu pode repensar, porque realmente tem vários elogios para a tua fala agora.
Eu não sei se ele está ouvindo, que está congelado.
Se congelou.
Robert,
Sim.
are you there?
Yes, I hear you.
Ah, ok. Pode ser em português agora?
Sim, vamos mudar a português. Agora tenho vocabulário, mas desculpe, por uma palestra assim, com palavras novas para mim, foi difícil para apresentar em português. E espero que
excelente,
a intenção
excelente.
foi suficiente claro em inglês.
Foi muito claro, eu acho que tu trouxe alguns pontos muito interessantes. Eu estava vendo ontem, a gente tem um programa aqui no Sul, aqui no Brasil, que se chama Fronteiras do Pensamento, e que tem, uma vez por mês, vem uma pessoa, um filósofo, um autor, alguma coisa, e por um acaso ontem, quem falou foi o Andrew Salomon, que é um autor americano, e ele né, falou, tem um livro muito sobre a depressão, e ele é diretor do Museu Metropolitan. Então, ele falando, e eu acho que numa das falas que ele trouxe a questão de que ele estava conversando com o filhinho dele, e aí o filho dele disse, eu tenho saudades da minha vida. Ele está há 6 meses numa fazenda no interior, ele mora em Nova York, ele está numa fazenda no interior, e ele dizendo, eu tenho saudade da minha vida anterior, eu tenho saudade de ver as pessoas, eu tenho saudade de conversar com as pessoas e olhar para elas, pai. E eu acho que essa questão do presencial, do toque, o humano tem essa necessidade, nós estamos num momento de isolamento que é para a nossa própria proteção e para os outros, mas eu não sei, assim, como é que a gente pode fazer essa aproximação, pensando que a gente tem que ficar ainda no momento, e a gente sabe disso pelos números que a gente tem visto por vocês, e nós aqui também estamos vendo, ainda temos mais uma longa jornada aí pela frente enfrentando essa pandemia. Como é que tu acha que a gente consegue? Não é só o trabalho, eu acho que tem uma questão aí também da questão da sobrecarga pessoal, né, quando a gente pensa nisso, né, porque a gente está muito distante das pessoas, até das pessoas que são queridas a gente.
É verdade, e desculpa, acho que a minha câmera não está funcionando, né? Você não me vê?
Ligar ela e ligar de novo, talvez funcione.
Vou tentar.
Não, ficou congelado. Mas o mais importante é te ouvir.
Pode me ouvir, né?
É isso aí.
Sim, é verdade. Essa ideia de isolamento social é um problema entre nós e nossas vidas pessoais, mas também na vida profissional, porque, bem, eu sou médico da atenção primária, estou acostumado a trabalhar em equipe. E estou constantemente com colegas de vários níveis de experiência, de várias culturas, etc., que trabalham corpo a corpo comigo na clínica. Agora eu trabalho de casa, do telemedicina, e a única conexão que tenho com eles é por mensagem do texto, ou às vezes faço uma videoconferência e uma reunião cada semana com vídeo, mas essa é uma mudança enorme em nossa maneira de trabalhar, e eu sinto que eu perdia muito poder de entender e impactar os pacientes, porque agora telemedicina é um trabalho muito solteiro, muito sozinho, totalmente diferente. E eu preciso compartilhar meus desafios, minhas dúvidas com meus colegas. Essa foi o chave da minha felicidade em 40 anos de trabalho em medicina, porque eu não tenho burnout, não estou infeliz, estou um médico bem feliz, mas o chave para chegar a essa posição, a esse lugar, foi para fomentar uma série de relações sobre muitos anos. E eu ainda trabalho com meu mentor, que é mais idoso que mim. E na mesma clínica. E estou muito triste que não posso tornar na cadeira e falar com ele para dizer: tenho um caso extremamente difícil. Isso foi meu pensamento. O que pensa você? No momento, no tempo real. E não posso fazer isso. Não posso. Difícil. Desafio. Mas escrevo do caso, e eu noto o caso e frequentemente ligo a ele para pedir aviso mais tarde. E eu também ofereço aviso da distância. Eu faço consultas nos pacientes de meus colegas e mando aviso a eles. Da minha perspectiva, fisicamente, emocionalmente, etc., eu quero recomendar que talvez pensem nisso ou mudem nessa outra coisa. Temos que manter nossa colegialidade assim.
Acho que essa troca é muito importante.
Eu coloquei no chat um artigo que saiu na edição do JAMA, 24 de agosto. O título é The Disappearance of the Primary Care Physical Examination, Losing Touch. E a última frase desse artigo coloca: In attempting to keep patients at a distance, I'm losing touch with a part of my professional identity. Então, isso é um aspecto que a gente vê muito nos nossos colegas, professores de medicina, né? Eles dizendo que eles estão frustrados em ensinar os alunos semiologia ou a prática clínica, não tendo a possibilidade de ensiná-los na beira do leito. Como lidar com isso? Com os colegas e também com a perda dessa interação, né?
E a única maneira que podemos fazer com nossos alunos é, se é idoso como mim, vincular o aluno comigo na mesma vídeo para condutar uma consulta de triplo parte. Mas perde muito poder de expressão da cara, de posição do corpo, o tuco, etc. Perde muito. Mas
non-verbal
non-verbal
communication.
É melhor que nada.
Sem dúvida. Mas de tudo que tu falou, eu acho que a mensagem do Take Home Message é que a gente tem que ir para Porto Seguro. Falou, né, que tinha...
Quando tudo espaçar,
Tu gosta de Porto Seguro, né, Robert?
Você sabe que eu vou lá frequentemente. Tenho bons amigos em Porto Seguro.
A Mariana...
Tenho vergonha para confessar isso, mas vou confessar a vocês. Eu fui para Areal de Ajuda, que é perto de Porto Seguro, para Carnaval, neste ano, 2020. E qual foi minha fantasia? foi uma camisa de cerveja Corona.
Não
E uma
acredito.
máscara cirúrgica. E eu fui o coronavírus. E todo mundo pensava que foi uma piada enorme.
Exatamente.
E quando foi na semana antes que chegaram os primeiros casos de coronavírus lá no Brasil. E agora, depois de tanto sofrimento, tanta mortalidade, tanto sofrimento em nossa parte, tenho uma vergonha enorme de brincar assim sobre um tema tão sério. Mas essa é uma confissão, quero dizer a verdade. Essa foi a minha fantasia de carnaval.
Eu acho que a gente tem esses momentos e o carnaval, enfim, ele proporciona isso. A Mariana de Oliveira, ela agradece muito a palestra, achou excelente. Ela diz: tivemos uma paciente na UTI neonatal, que passou a maior parte de uma longa internação vendo as pessoas de máscara. Mesmo assim, ela aprendeu a sorrir. Precisamos sorrir com os olhos para os pacientes.
Exatamente. Parabéns. Que bom comentário. Exatamente. Tem gente que colocaram suas próprias fotos no chaleco para mostrar o paciente.
Tipo um crachá, né? Grande, assim.
Isso é minha cara. Isso é minha cara.
Sorrindo. Eu vi vários profissionais fazendo isso. Um colega nosso, né, e colega Ayrton Maurício Soimbel, tá dizendo que ouviu várias palestras sobre o tema. Essa foi a melhor, objetiva, clara, com recomendações práticas, factíveis na nossa realidade. Parabéns, Dr. Janett, Maria Eugênia e ao meu amigo Ayrton Stein. É um colega nosso epidemiologista, então acho que é interessante colocar que realmente ficou muito claro. Eu gostei muito da questão que tu trouxe, da diferenciação entre o estresse e o burnout, principalmente também a questão quando tu traz a questão da moral, da lesão moral, né? E desse estresse moral que existe e que a gente está aprendendo agora, porque a gente vai. Eu sempre penso o seguinte: a gente está aprendendo isso, né? E a gente tem que ensinar isso para os nossos alunos.
Exato.
Então, eu sempre coloco atualmente para os alunos, digo, olha, antes a diferença entre eu e vocês é que eu cheguei primeiro, agora a gente está chegando junto, a diferença é que eu tenho algumas ferramentas a mais, mas eu nunca tive vivenciado uma pandemia, então para mim está sendo um aprendizado extremamente importante nesse momento, né? Então, acho que isso a gente tem que pensar ainda como é que a gente vai trabalhar isso.
Mas essa não é unicamente uma função do pandemia, é sempre em medicina esse desafio de moral injury, moral distress. Mas a coisa essencial é, primeiro, identificar que isso é presente, nominar, dar um nome. Isso é moral distress. E pode processar o problema, o ameaça a seus valores, sua filosofia, sua promessa como um profissional e falar como uma pessoa em que tem confiança se uma situação está acontecendo, porque assim podemos diminuir o PTSD, o trauma.
Estresse pós-traumático.
Yeah.
Isso eu ia te perguntar, Robert, tu tem identificado o diagnóstico mais frequente em pacientes com PTSD na tua clínica?
Sempre.
Um diagnóstico?
Constantemente, sim. Muito frequente. É um problema enorme em nossa comunidade. Eu trabalho no sector público, no rede público, então temos muitos imigrantes que foram vítimas das guerras, escaparam da opressão para chegar aqui. Temos os problemas raciais, que é muito bem publicado aqui nos Estados Unidos, de violência contra a população negra, etc. E temos esse racismo que é institucionalizado no regime do Trump, que
estrutural, né?
É estrutural. E por isso, isso tudo provoca trauma. E além disso, tem a violência que que é um componente de gente de baixa renda, de violência na rua, etc., de violência doméstica, tudo produz o trauma, e tem que respeitar o papel do trauma no desenvolvimento de vários sintomas em que enfrentamos na atenção primária. Mas, além disso, aprender que também nós temos nosso próprio trauma.
E tem algum manejo que é efetivo? Vocês fazem grupo de autoajuda, alguma estratégia como mindfulness, ou alguma coisa que vocês façam, assim, que é recomendável por demonstrar a efetividade?
Uau,
o medicamento?
É outra palestra de 1 hora. Você sabe, mas atualmente temos uma rede de saúde mental aqui, vinculado com nossa rede de atenção primária, como uma unidade com uma especialização em trauma. E eles podem atender os pacientes individualmente e em grupos, mas também eles ensinam a nós os ferramentas para identificar essa ideia de trauma e dar, por exemplo, seminários como se pode lidar com esses sintomas. Por exemplo, como pode resistir a tendência natural de ficar com ofensa quando o paciente explode em sua presença. Porque trauma tem 2 polos, passivismo e explosão. E pode ser uma ou outra, ou as 2. Então, se entenda isso, se entenda a dualidade do passivismo e explosão, pode esperar esse tipo de comportamento em seus pacientes, em seus colegas, etc. E quando um paciente está com muita raiva, com uma explosão, pode calmar sua própria mente e não fica em ofensa e pode continuar o relacionamento positivo com o paciente. E não estamos ainda falando sobre medicamentos, porque tem vários medicamentos que ajudam na situação. Tentamos evitar os benzodiazepinas. Essa é perla.
Que às vezes é difícil, né? Às vezes é o paciente que quer também, tem esse manejo aí que a gente tem que trabalhar.
E o uso de drogas listas e ilícitas, tu tem percebido como tendo aumento na tua prática clínica diária, Robert?
Usa dos drogas recreacionais?
Isso, alcoolismo, tabagismo e drogas ilícitas?
Problema enorme. E também em nossa rede pequena temos um centro de dar tratamento pelas adicções, e é outra coisa que fazemos treinamento por nossos professores, nossos alunos, nossos residentes, porque o problema é tão comum, se enfrenta diariamente.
Perfeito. Robert, queria te agradecer muito pelas tuas palavras e pela tua palestra, foi extremamente esclarecedora. Eu já mandei aqui, já estou conversando com meus alunos aqui, coisas que a gente vai poder discutir na disciplina de mentoria no futuro. Acho que a gente tem que estar sempre com esse tema na cabeça, porque é um tema que às vezes a gente esquece, né? Até de falar durante a formação dos acadêmicos, né? Eles sentem às vezes isso e não conseguem nem nominar, porque a gente acaba não tratando isso durante a formação deles, né? Então, queria te agradecer, foi extremamente esclarecedor e assim, te agradecer a tua parceria, porque a tua parceria com a nossa universidade tem sido enorme, né? E tem só abrilhantado mais a atenção primária que a gente tem trazido para dentro da universidade. Então, assim, eu queria te agradecer realmente pelo teu tempo. Eu sei que tu tá sempre na corrida e sei que, pelo que a gente conversou antes, que o teu tempo tá bem difícil.
Tenho uma tristeza enorme. Tenho muitas tristezas aqui agora, porque ontem foi 140 mil casos novos de Covid nos Estados Unidos. Estamos entrando em outra onda de doença aqui, temos muito medo. Tenho muitas tristezas da minha separação, da minha família, etc. Minha separação de meus pacientes, colegas. Mas agora tenho uma tristeza mais grande que tudo, que não posso viajar e não posso ficar lá presencial com vocês, porque eu tanto prefiro dar uma palestra assim presencial e depois ir por um botequim juntos para beber uma cerveja e conversar mais profundamente sobre todos esses temas juntos, porque agora temos que manter nossas conexões virtuais. E, bem, é melhor que nada, mas é uma tristeza.
Mas não faltarão oportunidades, tenho certeza que...
Vou receber a vacina no primeiro momento que é disponível e talvez, se tem um nível de eficácia de 90%, que a informação comercial, não é informação científica ainda, mas se esse nível de eficácia de 90% de Pfizer é correto, talvez me liberaram para viajar outra vez nas meses seguintes. Posso manter a esperança nisso.
Com certeza, todos temos essa esperança e a gente vai combinar. Muito obrigada mesmo.
Muito obrigado e nos mantemos em contato.
Colegas, amigos, boa noite. Obrigado pelo convite. Eu gostei muito.
Uma pergunta ainda, Robert. Só uma pergunta para te finalizar. A gente tem o nome do nosso seminário, se chama Respira e não pira. O que tu está fazendo para... Essa pergunta que eu sempre faço no final. O que tu está fazendo para não pirar durante a pandemia?
Bem, os pontos finais da palestra foram assim. Tem que aprender como se calmar, primeiro. Tem que cuidar-se com comida boa, exercise e descanso. Tem que escapar do stress periodicamente e passar em tempo refletivo de que dá a você motivação, carinho, satisfação de sua profissão. Porque isso, a satisfação e o carinho e motivação, essa vai diminuir os sintomas de burnout suficiente. Não está totalmente em seus ombros, porque burnout precisa mudanças multidisciplinares, multiníveis. Mas em sua parte própria, siga amistade, siga amor, siga suporte, siga mentoramento, mas atenda a seu próprio organismo, além de tudo.
Muito obrigada, Robert. Eu lembrei, Robert, numa troca de mensagem antes das eleições nos Estados Unidos, tu disse que tu estava com ansiedade e resoluto. O resoluto até foi procurar no dicionário, que é a mesma palavra em português, é ter mais firmeza em relação aos aspectos que trazem saúde, bem-estar, né? Então, ansiedade faz parte desse momento, né? Quem não está ansioso tem algum problema, né? Porque, evidentemente, todo mundo está ansioso nessa circunstância, mas tem que ser resoluto, né?
Porque sabe com certeza que será melhor.
Sim, com certeza.
A vida mudou, mas não é permanentemente assim.
É só uma etapa, né? É só uma etapa. Obrigado, Robert, realmente.
Prazer, amigos, colegas.
Boa noite. Tudo de bom.
Boa noite. Muito obrigada pela presença de todo mundo e quem está nos assistindo agora, mesmo quem está nos assistindo num outro momento. A gente está com uma programação bem intensa do Respira Não Pira e vocês podem seguir ela dentro do site da universidade. Muito obrigada, uma boa noite a todos.